Okay, this is going to be a quite interesting symposium. I think you are fortunate to be here because you will hear information which is not really known of public and so. So it's always interesting when you hear things for the first time. This is my potential conflict of interest. So the learning objective is to join this program if you want to learn correct interpretation of OCT-visualized dissection for optimized PCI approach with DCB or DES. Second point, to understand the importance of sufficient sirolimus vessel wall content and persistence over time after usage of sirolimus-coated balloon. Get an insight in the future of vulnerable plaque treatment with DCB, and finally receive the latest clinical update for bioresorbable with long-term follow-up.
Thank you, Patrick. I think Patrick is a physician that needs no introduction. Patrick Serruiz from Galway. And Dr. Serruiz will enlighten us regarding his talk on one of the most concerning things that I think when you are starting your program with DCB use, which is coronary dissection. Which dissection should we lift safely? In which dissection should we treat it with a stent? So please, Patrick, the stage is yours.
Thank you. So, dissection volume as predictor of DCB success. I modify a little bit the title, OCT-guided approach of DCB treatment. This is the potential conflict of interest. And then unresolved question on DCB treatment are the following. Question 1, how frequently dissection is observed during DCB? Question number 2, how to quantify dissection? And is the measurement reproducible? Question number 3, is the dissection volume associated with angiographic late luminal loss or gain at 6 months? In the Transform 1 trial, luminal dimensions was assessed by OCT after pre-dilatation and used to select the most appropriate caliber of drug coating balloon to optimize the wall position and drug transfer to the vessel wall, to quantify by OCT with a new software the balloon-induced coronary dissection, and finally to elucidate the impact of dissection volume on late angiographic outcome, gain or loss. As you could see on the right-hand side, we have an histogram. That's the ratio of DCB nominal diameter and the reference vessel diameter assessed by OCT. And that ratio was close to 1 of 100% in the Transform trial comparing sirolimus and plaque DCB. This is a beautiful example of absence of obvious angiographic dissection and the presence of a massive dissection on OCT after pre-dilatation. In this case, the dissection is starting on frame 138 and going down all the way, and the next slide is finishing on frame 260. So that means that the length of dissection is not 12 but 24 millimeter. In the quantitative analysis of dissection, we developed a novel software, and as you could see, the edges of the flap is connected, and the connection delineate on one hand the lumen of the vessel, and on the other hand the dissection area, the length, area, volume, and arc of dissection can be quantified. You could read the number on the slide. What are the essential results of the OCT assessment? There was, in general, a huge discrepancy between the angiographic assessment of dissection according to the National Heart Lung Institute and the OCT assessment of the dissection. On OCT, 95% of the lesions are dissected, whereas on angiography, only 15%. The method is robust, with very good reproducibility and a Pearson coefficient of 0.96. The median dissection volume was 2.12 cubic millimeter. And there exists some heterogeneity in the extent of dissection created by the operator. Let's go back 35 years ago when we used the plain balloon angioplasty. In 1988, published in Circulation, we put back on the table of the cath lab at 1, 2, 3, and 4 months 4 cohorts of patients and analyzed their angiographic luminal late loss over a period of 4 months. The late loss increased progressively and culminate at 4 months with a loss of 0.42 millimeter. A few years later, in 1994, we pooled 4 unsuccessful pharmacological trials on restenosis and established that the loss was a function of the gain, a linear function of the gain, with as covariate the MLD-pre. The regression equation in these 3,076 patients indicate that for every luminal gain of 1 millimeter, we lost 0.6 millimeter in angiographic late luminal loss. Still today, if you analyze the mixed group of sirolimus and paclitaxel drug-coated balloon in Transform-1 trial, we see the same ratio of loss, about 60% of the acute angiographic luminal gain. However, if you split the relationship of late loss and acute gain between the 2 drug-coated balloons, we realize that the vessel treated with the sirolimus lose 0.72 millimeter in late loss for each acute angiographic luminal gain of 1 millimeter, while in the paclitaxel sequence please neo, angiographic luminal loss is only 0.37 millimeter for each acute angiographic luminal gain of 1 millimeter. And there is a trend for p-value interaction of 0.065. If we analyze the relationship now between the angiographic late luminal loss and the dissection volume determined on OCT, we see that the sirolimus magic touch has a positive coefficient of 0.049, while the paclitaxel sequence please neo has a negative coefficient of minus 0.10, and there is a significant value this time for interaction. If we isolate the relationship between dissection volume and angiographic late luminal loss after treatment of paclitaxel drug-coated balloon sequence please neo, we have the temptation to raise the following question. Is the axiom of POBA, the more you gain, the more you lose, still true in the era of drug-coating balloon with paclitaxel? However, this information has to be confirmed, and we hope that B. Brown will be involved in this important confirmation for the community of the interventional cardiologists. Essential to remember, in the era of POBA, acute luminal enlargement obtained by coronary arterial dissection came with the drawback of restenosis at midterm. In the Transform 1 trial, coronary dissection after pre-balloon angioplasty was assessed quantitatively by dedicated OCT software. After sequent please neo treatment, the dissection volume was no longer associated with late luminal loss. Furthermore, although not statistically significant, a coefficient was observed with late luminal gain. The famous motto, "the more you gain, the more you lose," may be no longer true in the era of DCB with paclitaxel. Thank you very much for your attention, and we will discuss that later on. Okay, now we have Victor Jimenez Diaz with deciphering the challenge of sirolimus and sufficient vessel wall persistent with OCT. You're ready, sir.
Thank you. Well, indeed, it's going to be a challenging task to deliver my lecture after Patrick's talk, but I will do my best to provide you with novel information regarding the drug transfer and persistence of the sirolimus drug in the vessel wall after DCB PCI. These are my conflict of interest. So I think it's fair to say that we have learned a lot from the first generation to the second generation of DCB using paclitaxel. And the companies have overcome a lot of difficulties to get the right device and to put it in our hands. But now we know how to do a really good DCB balloon, and now we know how to deliver a better treatment for our patients. And all this knowledge has been taken and put it into the manufacturing and development phase of the sirolimus-coated balloon. But mainly the main issues and the main hurdles that the companies has with sirolimus-drug-coated balloon was three. One is the drug transfer. They have to improve the drug transfer to the endothelia, the absorption of the drug in the vessel wall, and also the drug retention. As you know, paclitaxel and sirolimus behaves completely different from the endothelia to the media and from the media to the adventitia. So that is why when you see the landscape of Limus DCB, you will see that all devices are different. Mostly uses sirolimus in a different component way, but all the drug contents are different. The excipients are different also, coming from BHT to PEO to phospholipids to microreservoir and also to bioresorbables nanoparticles. So not all drug-coated balloons are the same, this is clear, and each devices have to be tested in the preclinical environment and then have to be proved in the real world arena or in humans. So because all the information that we can get from the histopathology analysis and tests, it's give us a hint of how this device will behave in a clinical scenario. But even with such a nice papers and nice research that you see in the screen, there is still remains uncertain or questions opens in the air when you translate this data to the clinical scenario. And this is mainly because all these devices has been tested in young and healthy arteries of animals. So they lack of condition of human atherosclerotic disease, and this is a big issue. So what we like to have is to get this information, but in humans, in a real scenario. So there was a series of cases showing that acute paclitaxel deposition in the vessel wall was feasible to observe in stent restenosis patients. They do it with angioscopy, which is a tool that we don't use in daily practice, but also by OCT you can see these bright spots of paclitaxel in the endothelium of these in stent restenosis patients. But what about sirolimus? Can we visualize sirolimus acutely? And now that sirolimus is the new kid on the block in DCB era. Could also see it in de novo lesions, not only in stent restenosis, and de novo lesion is the big target for these devices. Can we see it in acute coronary syndrome also? And more important, can we assess its permanence on time in the vessel wall. Well, this is a 50-year-old woman that was admitted for an acute coronary syndrome due to a atherosclerotic plaque in the distal right coronary artery. As you can see in the right side of the screen, there is an OCT showing a fibrolipidic plaque in a really tight stenosis. So we conducted a pre-dilatation with semi-compliant balloon, non-compliant balloon, and the pre-dilatation was okay. You can see some dissections after pre-dilatation on OCT, some minor dissections, some not so minor dissections as we saw in the previous slide. But we continue ahead with a DCB PCI. We did PCI with a sequence sirolimus DCB in this patient, and the acute angiographic result was very good. But also we did an OCT in this patient, and we were able to see and to analyze these images in the endothelium. This is the crystallized sirolimus all over the endothelia that was treated in the right coronary artery. You can see at different sizes, different disposition in endothelium, but also very interesting how to see this shadowing behind the drug that is mimicking what we've seen with a metallic stent strut. So we can assess the effect of this drug in the endothelium acutely. But we conducted a follow-up at 1 month in this patient. You can see the angiographic result was really good outcome with this patient, but we continue doing an OCT in this case. And we were able to see that all these images practically were endothelialized and adopted, were embedded in the endothelium or in the media of the artery wall. You can see it well distributed in all the treated part of the vessel 1 month ago. And this is also similar what was previously described in the histopathological analysis of sequence please neo with paclitaxel, but now you can actually see it in a human with a sirolimus-coated balloon. And these particles can be traced, can be measured, and can be also traced over time, and you can see how they are functioning in the endothelia. This is another example of an acute coronary syndrome due to a tight stenosis in the proximal LAD treated with a sequence sirolimus-coated balloon. But this was a ruptured, a vulnerable plaque in this patient, very young patient. So you can see after the treatment how these small particles of drug are completely in the surface of this eroded or ruptured plaque in this patient. And we conducted a follow-up at 45 days after the initial treatment, and you can see that the angiographic result was okay, still good. But also you can see that these particles were completely endothelialized and embedded in the media of the vessel wall, exerting this anti-restenotic effect in the media of the vessel. And also you can see that the rupture plaque was healed or in the process or being healing. Finally, we have a series of cases on you can analyze these different patterns of drug distribution in the vessel wall, and this is a research that we are conducting currently. So as a take-off message, there is no class effects on DCB, and this applies for paclitaxel and sirolimus drug. So each technology must be validated with preclinical and clinical evidence. So data on sirolimus is coming, and it's coming really fast. So we have to be prepared on that. And intracoronary imaging techniques can be useful tool like research purposes, not in our daily practice, to assess the acute drug transfer and its persistence over time. So I think it's fair to say with the data that we have with paclitaxel and sirolimus that no leap of faith can be claimed anymore for the use of DCBs. These are real and they are useful tools in our daily practice. Thank you very much.
Fabulous pictures. I mean, as a matter of fact, the Japanese published for the first time these crystal of DCB in 2015, and I send you the paper because.
Correct.
But then, in the meantime, you have the Lancet case report, and what you have shown today is very interesting. And I'm sure during the discussion there will be a lot of question about. What does it mean? Is that a marker, a biomarker of activity? We will discuss that. Okay, so the next speaker is Anna van Velen from Amsterdam, Navigating the Future of Vulnerable Plaque Treatment with DCB, an imaging-based approach. That's the uncharted field, as we call it. Yeah.
Okay, thank you very much for the introduction. And I would also like to thank B. Braun for the invitation to present here today. So I will share with you the findings of our WLRP study, where we investigated the novel application of drug-coated balloons for the treatment of vulnerable plaques. So as you might know, non-culprit vulnerable plaques are present in around half of patients presenting with acute coronary syndrome, but it's often hard to identify them with standard angiography since they mostly do not cause lumen compromise. But we can identify their specific high-risk features, such as their large lipid-rich necrotic core, with intracoronary imaging techniques such as IVUS combined with near-infrared spectroscopy or NIRS. And the presence of additional non-culprit lipid-rich plaques is associated with an increased risk for MACE, even despite guideline-directed medical therapies. So therefore, local treatment options are being explored on top of these guideline-directed medical therapies. And there have been 2 studies to date that investigated the impact of prophylactic PCI of vulnerable plaques. And the first was the Prospect Absorb study that demonstrated that prophylactic PCI with bioresorbable scaffold was able to reduce the plaque burden and the lipid burden and to enlarge the MLA. And then the very recently published PREVENT trial that just came out in The Lancet in May this year, in a large cohort of patients, in 1,600 patients, demonstrated that prophylactic PCI with bioresorbable scaffold or a drug-eluting stent led to a significant reduction of MACE at 2 years follow-up compared with optimal medical therapy alone. But we believe that drug-coated balloon could be a safe alternative and perhaps a more elegant alternative to stents or scaffolds, since it allows for a very local drug delivery without leaving behind a permanent implant. So therefore, we initiated the WLRP study, where we aim to evaluate the impact of paclitaxel-coated balloon treatment of lipid-rich plaques on the reduction of the lipid burden in terms of the maximum lipid core burden index in a segment of 4 millimeters, as measured with NIRS. And this was a pilot study, so we aim to prove the concept, and therefore we aim to enroll 20 patients. And we screened patients presenting with non-ST segment elevation acute coronary syndrome. And after treatment of all flow-limiting lesions, we performed 3-vessel IVUS NIRS. And when we identified an additional lipid-rich plaque, which was defined as a lesion where the max LCBI in a segment of 4 millimeters was higher than 325, which is based on the Prospect 2 study, these patients would undergo paclitaxel-coated balloon treatment with the sequent Please Neo of 1 lipid-rich plaque. And after 9 months, these patients would come back for the follow-up imaging, including 3-vessel IVUS NIRS, for the primary endpoint of the change of the maximum LCBI from baseline to 9 months follow-up in the lipid-rich plaques that were treated with PCB. And after 1 year, the patients would come back for follow-up, clinical follow-up. So this is an example of a patient that was screened for the study. So after treatment of flow-limiting lesions, we performed 3-vessel IVUS NIRS. And in the middle, you may appreciate the chemogram that is provided by NIRS. And we found a lesion where the max LCBI was 466. So this lesion was then treated with paclitaxel-coated balloon, sized 1:1 based on the IVUS to the lumen and with low balloon inflation, so only nominal pressure for a duration of at least 60 seconds. And this patient will come back after 9 months for the follow-up imaging. Here we have the baseline characteristics of the study, so not very surprising, with a median age of 66 years old and a baseline LDL of 2.8. And the procedural characteristics demonstrate that most lipid-rich plaques were located in the LAD, and that all lesions were treated under nominal pressure, so only 6 atmospheres, for a duration of at least 60 seconds. There was one complication that occurred, which appeared as distal embolization, and this resolved quickly after intracoronary adenosine and nitroglycerin administration, and alternatively, this could also have been spasm. So then on to the primary endpoint, which again was the reduction of the maximum LCBI of the lipid-rich plaques that were treated with paclitaxel-coated balloon. And at baseline, we found a median LCBI of 397. And after 9 months, this significantly decreased to 211, which was a relative change of minus 42%. And in contrast, the vessels that were not treated with paclitaxel-coated balloon did not demonstrate any change in the LCBI. Then we did find numerical changes in the IVUS and QCA measurements in the lesions that were treated with paclitaxel-coated balloons. So we did find an increase of the MLA and a reduction of the plaque burden, but these changes were not significantly different. The 1-year clinical follow-up demonstrated no LRP-related cardiovascular events. So back to the patient I presented earlier, where we treated the lipid-rich plaque in the circumflex artery, which had an initial LCBI of 466. And after 9 months, this patient came back, and you can appreciate the angio on the left. And all the yellow disappeared in the chemogram, so the max LCBI was now 112. So what can we learn from WLRP? That it was a first-in-human study where we investigated the proof of concept of paclitaxel-coated balloon treatment of vulnerable plaques. And we demonstrated that preemptive paclitaxel-coated balloon treatment of lipid-rich plaques was feasible and led to a significant reduction of the lipid burden in terms of the max LCBI without major safety concerns. And the study had, of course, a limited sample size since it was a pilot study with only 20 patients, so further research is needed, and we're currently working on a follow-up study. So thank you very much, and I would also like to thank the WLRP study team, and we'll take the questions later, I think.
Very good.
Thank you, Anna. Now the next speaker is a pleasure to introduce Matthias Lurz from Kiel, Germany, and he will talk about the bioresorbable scaffold renaissance. Long-term data unlocks the next generation of PCI toolbox, which is, I think, the perfect complementary device for the DCBs. So please, Matthias.
Thank you, Victor, for the kind introduction. These are my conflicts of interest, and I will show in the next minutes or a report about a second generation bioresorbable scaffolds of Phantom BRS. So it's a newer device. It's a scaffold design with very thin struts, 125 microns, with an enhanced radial strength and with a very good post or over expansion rate. The material is different from the PLLA, which we know. So it's a polymer and polycarbonate based on the aminoacid acid tyrosine. It's radiopaque, so you can see it in X-ray. The vessel is uncaged at almost 1 year, and the complete resorption time is more or less 4 years. It's the drug on the top is sirolimus, and the BRS is mounted on the delivery system, semi-compliant rapid exchange, so it's not very special. So the Phantom 2 trial was a safety and performance study to get the CE mark. Briefly, 240 patients in 2 cohorts. 28 clinical centers were participating and including this patient. The main inclusion criteria was reference vessel size from 2.5 millimeter to 3.5 millimeter and the lesion length below 20 millimeters. So there was several time points of follow-up, 6 months angiographic and 9 months angiographic follow-up regarding cohort A and B. The main treated vessel was the LAD with nearly 50%. The lesion characteristic was mainly type B1, but also some more complex like B2 and type C lesions. And the procedural outcomes was very good with a clinical procedural success of nearly 99%. These are the 5-year data with a MACE rate of 6.3% and a target lesion failure rate of 5.8%, mainly driven the MACE rate by the clinical driven target lesion revascularization. And if you look to the Kaplan-Meier curve, you can see that we have in the first year a clearly raise of the event rate, and after 1 year the event rate goes down. And also if you look to the target lesion failure curve, it's the same course. First year increase of the events, but after 1 year the event rate goes down. Looking to the thrombosis rate, very interesting topic regarding bioresorbables. You can see that we have only 3 thrombotic events through the whole trial, 1 subacute after or in the first month, and 2 very late problems or events after 1 year. And if you look to the curve, you can see that after 3 years, there was no further thrombotic events in the whole trial. These data were published last month in the Eurointervention. We added some OCT analysis revealing the good healing pattern of this device in the vessel wall. In the meantime, there's the third generation of this device developed and get his CE marked approval. So we were discussing in the Phantom 2 trial about the Phantom device with the 125 microns. If you look now, the Phantom Encore, the third generation device, went down with the strut thickness. So the 2.5 millimeter device have a strut thickness of 95 microns, 3.0, 105 microns, and the 3.5 device have 115 microns. And this is very important with the same radial strength, so there's no difference in the radial strength, but a reduction in the strut thickness. So this is a short example of one of these treatments, a young male patient with stable angina in the RCR2 DES, and this LAD lesion was treated with two Phantom 3.0 and 3.5 devices. This is a 6 months follow-up, and the OCT reveals also a very good integration and healing after 6 months in the vessel wall. So coming to my conclusions, with this next generation device, overcome the downsides of the first devices. We have seen sustained safety and efficacy up to 5 years with a lower TLF and MACE rate. The MACE curve flattens after 12 months clearly, and I think with this Phantom Encore third generation BRS device with the Sinostruts of any clinically available BRS with no compromised radial strength or radiopacity, we have a next piece in our PCI toolbox. Thank you very much for your attention.
Very, very good. So let's see how much time we have for discussion. I think it's the second column, so it should be 14 minutes. That's very good. So maybe we can do one by one. I'm not going to ask a question to myself, but maybe the panel has a question for me.
Oh, definitely. We have some question, but I want to ask the audience if they want to have a question, just raise your hands. There is a microphone there. Please feel free to do it. In the meantime, there is a brave from the audience. I have some question, or you have some question for Patrick? Okay, Patrick. Definitely, there is interesting data that you show us to us. But the software that you are using to detect this dissection, first of all, is an automatic software, or you have to do it by yourself? And second,
semi-automatic, but will be very easy if the industry of imaging is interested to make it automatic. I mean, there's no problem. It's very interesting is that all the important company of OCT, drug-eluting stent have not yet approached the imaging of the DCB. And one of the predictions that we did with all the experts for the consensus arc for DCB is that the imaging and the physiology will come in the field. You know, when we asked Antonio Colombo to do this OCT after pre-dilatation, you will not believe what Antonio could be dangerous. That it could be dangerous, but nothing happens in that trial. So the fact that you inject 3 ml per minute or 4 ml per minute to get the image is not increasing the dissection whatsoever. So I think that will continue to come, and I really believe at the center, at the end of my talk, I hope that the company like Big Brown will go in that direction and further explore that, because it's so important to realize that today it's not like in the good old day of balloon angioplasty. Now we have prasugrel, we have ticagrelor, we don't need even aspirin. Yeah, that's my guess. I think you can really do a major dissection and get that very well tolerated, and then you have a rebuild with remodeling. Yeah.
Actually, in the era of POVA, have a dissection was a sign of good outcome at the end, right? So, Matthias, we know that with the first generation of BRS, we know where they fail. We know what type of lesion we should avoid. But in your data, in your presentation, can you tell us something more about if you treat complex lesions, long lesions, acute coronary syndrome? Give us a hint on this.
Yes, so in this Phantom 2 trial, there were very easy lesions to treat because it was a CE mark trial, but we have some sub-studies, or we have a big sub-study with more complex lesions, with the longer lesions, and where we treat bifurcations, but in a provisional manner. With very good data. So we have a poster here for the 5 years data of this. And we have also the post-market trial. This is a regulatory trial where we include ACS patients, CTOs, all the real-life data patients. And for the post-market trial, we have 2-year data with very good results too.
Let's make a test, and let's ask the audience, do you believe that there will be a renaissance, because that's the word that we use, in renaissance with the bioresorbable? Don't forget, you have magnesium, you have iron, you have this one, the Phantom. There is new generation, which is not a block of polymer, but film of 7 micron, very strong. So there is a lot of technology there. The drawback a little bit is that with the syndrome of absorb, everybody and the regulator want to have at least 3-4 years. I mean, they're still watching. You had the one thrombose after 3 years. So there is a vulnerable period. So if you believe that bioresorbable, one way or the other, will come back, raise your hands.
Should we vote?
We can vote, I mean, yeah. So I would say is a small 30-35%. You agree with that visual assessment, yes. Non-quantitative, etc. So I think that's important. What is very difficult today is to say at what stage the interventional cardiologist will mix all this technology. You know, there's still stent trial, drug-eluting stent, but you can do a lot of things to do. You can do lithotripsy, rotational, directional and DCB, yep. Something practiced in Japan, very, very interesting. You remove the plaque and you put the drug. So when you see all the possibility that we have, are we going to mix that? We call that blended therapy and not hybrid therapy, because I keep saying hybrid in the nature die, but blend is fantastic, a blended whiskey of blended Margot plus this, etc. So what is the feeling of the audience? Blended therapy will be the future? Raise your hand if you believe that. Yeah, it's still shy. I mean, I thought that would have been much more because, you know, take a solution. If it doesn't work, you put a stent, but it's not a penalty. It's just an alternative treatment. That's the way to consider. And we recommend that in the ARC consensus of DCB. Don't penalize the DCB because the dissection was too big. Maybe the big dissection is good, by the way, but that's it. So I have a question for you.
For me?
Yeah. I mean, I was quite fascinating by your pictures. Sometime, and you described 3 types. You described focal, segmental, clustering, and then there was a beautiful example of circular. Yeah. Many years ago, when we start with Professor Onuma on the drug-eluting stent, we were looking on the frame by frame, the clustering of the struts, and I could not understand that. Why on one cross-section you see a lot of struts in the corner? And it's only when we did three-dimensional approach that we realized that we could reconstruct the whole stent. That's what I would advise to do for you. You might be surprised that what is clustered in one slice became connected and much more circular, because that will be very important. The second question, looking at your pictures, you said, here is the crystal. You have obviously a shadowing behind. That's the marker of the crystal, and it gets endothelialized. And the question that I had, and probably you have a very good answer for that, is the crystal 100% the sirolimus in your case, or is that a substrate, a crystal substrate, but the sirolimus has disappeared? Because otherwise I don't understand if the crystal of sirolimus is made purely of sirolimus. I don't see how the endothelial could grow on this thing. So can you try to answer that question?
It's marvelous that you asked me one question, the first one, and you already answered, so there's only one question. So, but for the second question, it's really difficult to answer, but the only answer that I have is, if you lose all the sirolimus, then the outcome is going to be bad. It's going to be a POVA. And from the series of patients that we have, and we have a long series of patients, the result has been superb. So I'm afraid that sirolimus stays in the vessel and exert the effect.
No, but what you do is very, very important. You know, it's many years ago for biodegradable stenting, we were using with Yoshi the echogenic syndrome. We correlate the molecular weight of the polylactide with the echogenicity. It was a beautiful relationship in a lot of animals up to 48 years. You have potentially now a technique to see the quality of the deposition and probably the retention, and also the retention. So that's very, very important. This meeting is small group, but it's really looking in the future, you know. You will leave that room with a few more ideas for the future.
But one real future is the treatment of vulnerable plaques. I mean,
yeah.
This is
so you know, I've judged that email when it was that abstract when it was submitted. I have a few questions. You know, at some point we were using filter. You will remember we did that a little bit in the coronary. It didn't work very well. We went to the bypass graft where it was somewhat more easy. And sometimes it was dramatic, you know, in these bypass grafts you have what we call vulnerable plaque, and then we were collecting the whole things in the basket, and there was no flow for a few seconds. You remove the basket and the flow was impeccable. So the question is, when you have on OCT a juicy vulnerable plaque, you know, on OCT 60 micron, a big necrotic core, the lumen is 0.39 in millimeter square. Do you feel confident to do that?
Well, I think we were, of course, very scared at first to do this. So that's why we chose to size the balloons to the actual lumen. So we sized it to just touch the plaque really softly with only nominal pressure, to be very careful. And we did IVUS nurse directly after treating, and we did not see any movement of the yellow, so to say. So, I mean, we were scared that we would lose the yellow right away, but it didn't. So it actually seems that it's an effect of the paclitaxel, of the medicine itself, and not directly from the balloon inflation that we did. But I think it's also because we chose to do it very softly, like I said.
Very good. Now, I have two additional questions there. What about the troponin? There were a bump of troponin after the treatment?
We did not routinely collect the troponin, so, but we.
I knew the answer, therefore I asked the question.
Yeah, no, so we chose to do it just clinically and just to see if the patient developed any chest discomfort and EKG changes, but that didn't appear. No.
So that's also something that could come back. You know, I'm old enough to have seen recycling of technology after 10 years, 20 years. And so I think that the filter is something would come back, because you have graphene, which is one layer of carbon molecule, okay, but very, very solid, okay. You could have a filter with graphene, and then you would dare really to have a juicy, vulnerable plaque that we don't dare to touch. We can put a scaffold, you can put a stent, because it will be between the grid. But just a balloon, if you do a little bit too well, it can be a catastrophe. So I think that it's not impossible that at some point it will be a combination of two for the vulnerable plaque. You had enough time to ask, to think about questions. So where are the questions? Yeah.
I'd just like to ask the crystalline form of sirolimus. Do you have an idea, assuming that's not bioavailable in the crystalline form, do you have an idea of what the bioavailable concentration is in the tissue? And secondly, how long does the crystal survive in the wall? And so how long would that effect persist?
Yeah, thank you for that question. The first question is really key, and we are in the process of getting that information. It's going to be something that involves intravascular imaging, of course, but also the histopathology field. So we are working on that, and that is the key aspect, because you can link, once you get that information, you can link to clinical outcomes. So that would be wonderful. And the second question was, how long the crystal will survive. Okay, so there is a nice publication by Kleber in Circulation in animal model, when he states that 40 to 50% of all sirolimus that is delivered in the vessel wall stays at least 1 to 2 months. So that is also we are seeing in the clinical practice. As I mentioned, we are not measuring the doses of drug. We are working on that, but I think it's the future of research in this field.
Can I maybe ask another question about this? Because would you advise, if you do imaging after you did the balloon inflation and you see not so much deposition as you want, would you advise to go back, take another balloon, do it again?
Well, that is a good question. I don't know how much is too much and how much is too low. Yeah. So we are really in an early stage, but I mean, we are getting information and knowledge. We are learning with this. So I think we need to wait a little bit more time and to do more research and to get more clear answers about what are these crystals, are they working well? I think the clinical outcome is there, they're going good, but we need to get more time and more research on this.
And everybody should realize, I mean, in that paper that I was showing on the axiom, etc., there is a good illustration about all the crystal. It starts by 20 micron, that's the smallest I have seen, up to 750 micron. It's huge, okay? So there is a big heterogeneity. And my last question, because I see the lady looking at the clock, the last question for you will be, what kind of sirolimus was that? That's a good one. Huh?
That's a good one, was the crystalline sirolimus from B. Brown.
Okay.
Okay.
I promise and I swear that I didn't know that, and I asked the question by accident. Yeah. Thank you very much. I don't think we need the learning message. I mean, it's so obvious that it's time to leave the room and go for something else. Thank you very much.
Thank you.